Welcome to Dental XP webinar. My name is Dr. Dean Vopfiadis, and we're going to be talking about computers and dentistry for private practice, abutments, ceramics, and occlusion. I've been teaching for 17 years at the NYU Dental Center in different capacities. Right now, I'm the program director of the Full Mouth Rehabilitation Program, CE course. Some of the companies we've been working with over the years, the disclosure is here, and some great relationships have been forged in the last 5 years with these computer companies. So we're going to talk about digital dentistry, how intraoral scanning can actually help the practice, save a lot of time, save patient chair time, and actually produce some great restorations in a lot less time with a lot less headaches. We're going to talk about which system is right for your practice and does it really work? Is this technology really mainstream, or is it still on the learning curves and there's things to be advantages of? But the advantages are here, where we're using it on a daily basis, restorations, crowns, veneers, jackets, crowns, on implants and on teeth. And how important is it for your practice? And we'll show you a couple of benefits that you may help you make the decision about the best scanning system and where the future is going for the digital dentistry. So we started taking digital impressions about 5 years ago. There's 4 major companies that are digital impression acquisition units. We started with CEREC, then we acquired the Lava scanner, which is a COS chairside oral scanner, and now we have the E4D. There's also the iTero, and we'll be talking about the benefits of each one. For posterior restorations, it expanded our horizons because we were able to now take digital impressions of the coated abutments, and we'll show you some case presentations on that. And now with anterior restorations, we can do veneers, jackets, and of course anterior implants, which really help us control the emergence profile and the type of ceramics that we're using to get really good natural looking crowns. So digital dentistry for us had started with implants, the Encode coated abutment had allowed us to start taking our images of our implant impressions without fixture level impressions, and we'll discuss that in a little bit. Let me just kind of hold in on the restorative consult and how we approach the patient from start to finish, so at least you get a handle on how we do our consultations. We look at facial aesthetics, smile aesthetics, and tooth aesthetics. We take a lot of photography in the beginning, and that helps us analyze the patient and be able to really control the conversation with them and actually show them different things on the screen. For what we believe is the steps to ensure success no matter what restoration and what kind of patient you have, we take a full mouth series of x-rays. Obviously, it'll be probably digital. We'll do a digital photography of the lips, the face, the extraoral features, their side view profiles, cephalometric x-rays, as much as we can get, and try to do that at our first visit, so we get really the good records. We then establish incisal position if we're doing any kind of aesthetic work with either wax or with composite bond-on technique to show the patient the possibilities. And then we discuss their expectations if they're doing anterior restorations. If they're restoring their whole mouth, then we'll get into a second type of diagnostic session to talk about reconstruction. But if we're talking about anterior smile design, we try to do it that day. One of the problems in fabricating our normal restorations is the pouring of the models, the impression taking, the time it takes for the laboratory to fabricate it, the mounting of the models, which is something that's very inaccurate today. And with digital dentistry, we can make that a lot more accurate. The time it takes to make a full crown, a single unit crown for most people, is usually about 8 hours in total. And of course, the 2-visit protocol is normal for most patients and most dentists. What we found is with the CAD CAM dentistry, we're saving a lot of time. We're fabricating the crown in one visit. The patient's only there once. So we're reducing a lot of time in our office, and of course, the patients appreciate that. The second piece of that is when you reduce the time of the making of the fabrication of the crown, you're going to reduce time for your office, which is going to increase your profitability in terms of how much time it's taking you to make one single unit crown. Now, the average in the United States of single units, the average dentist does about 67 or 70% single restoration. So that being the case, we realize that CAD-CAM technology is going to help us to decrease the time of that fabricating of the crown. The abutment design is another issue that has been perfected and kind of gotten a little easier to get the abutment design to get a better emergence profile. So that also, from the digital perspective, is easier to control the emergence profile. In terms of anterior teeth, we've all done single unit restorations, trying to match shade matching of the adjacent teeth. and we have multiple visits with the patient, maybe even a laboratory visit to try to get the color right. And with the CAD CAM technology today, we can do that in about a 2-hour visit appointment and really get the color shade match right on target. So that helps us, again, just saving a lot of time for the patients and for the dentist. Since 2005, the major companies right now are Lava, which makes the 3M software, which is a digital scanner. The iTero Cadent is also a very good scanner. The digital impression and in-office milling has been CEREC InLab, and now we have the E4D, which is really our mainstay today for single unit restorations. The CAD CAM abutments have been around for many years. The Encode is what we're primarily using because it doesn't need for you to take off the healing cap. The healing cap actually has the CAD CAM coded abutments that you can scan or take a final impression with without taking off the healing cap. So those are the three types of families of digital dentistry that we're using on a daily basis, and they integrate with each other very well. So the 3M has the COS intraoral scanner, and this is just some photography of some cases that we've done and full arches. The Cadent iTero, again, a really good scanner. The models are very good. We do not have this machine at this point, but it's a very good scanner. A lot of people have been very happy with it. Again, the benefit that we see is the occlusal bite registrations that are really accurate. When we're mounting the model on regular stone casts, that occlusion may not be perfect, depending on who's mounting it, if it's a quadrant, if it's a full arch. That accuracy is not 100% there, and that's why we find ourselves grounding our porcelain when we're trying in our restorations. With digital CAD CAM, that occlusal registration is done on a CAD CAM with 3,000 or more pixels that gives you a beautiful, perfect occlusion. So when the model comes back, that occlusal adjustment is minimized. Again, time is saved and the accuracy is there. The E4D has given us some great versatility in making the actual crown. The design work for me is a lot more fun. It's a lot more exciting. I can really look at all different aspects of the tooth when I'm designing it. CEREC is also very popular, has some very good techniques, and it's been around for a long time. So that scanner is good. I want to make something very clear. All the 4 scanners that we've used, excellent scanning capability. It's not one is better than the other. So my suggestion is always sit down, play with the computer, play with that software, and see which one you like. It's sort of like an iPad and an iPhone and a BlackBerry. Some people really like one or more than the other. But they both really work well, and they give you great results. For the in-office milling, again, for us, it's saving time a second visit. It's saving the patient time of coming back and getting a second injection. It's getting us more control on the final restoration. And, of course, we know that dentin that's prepared and enamel that's prepared, it's a lot better when it's sealed the same day. So you're getting one visit, preparation, and seal the same day, which could help you with the sensitivity long term. So that's really been a big help. Gordon Christensen and Todd Schonbaum have published different articles which show us the inadequacies received by the labs from the regular stone casts, and the shift of digital impression may be revolutionary, as Dr. Schonbaum explains. Primary advantages: avoiding the impression. That's been always a problem for the patient. The alginates, all that, the delivery, the Pindexing, the ditching, reducing of the lab bills, and basically saving time. Secondary advantages: most accurate interocclusal records is my #1 advantage in terms of looking at things. The margin capture is easy. You can actually ditch your die. So this is going to create a lot better accuracy for your restoration. So if you're actually ditching the die on a digital scanner and marginating, it's a lot better than someone in a laboratory who's basically under a microscope trying to figure out where your die is. So ditching your own die, looking where your preparations, it's going to give you less remakes. It's going to give you a better marginal adaptation. Again, saving money, materials, trays, assistance time of pouring, and of course the wow factor for the patient. Additional advantages: promotes better dentistry, promotes better preparations. You're cleaner, your feel is easier. If you have a lot of blood in the area, then you have to kind of step back and not take that impression. So that kind of controls the scanning ability. So you don't want to have an area where you have a lot of blood or fluid. So that kind of forces you to clean up that site and wait for the perfect impression instead of kind of using an Impergum type of polyvinyl siloxane and trying to get that margin. This kind of makes sure that you're going to get a beautiful impression each time. Also, when you have trouble and you have some issues with the design team, the design team can be called up on your phone call, and they can basically help you out. Disadvantages: some people say the cost of the scanners is a disadvantage. I feel that the cost can be amortized over 5 years. If you look at the monthly laboratory bill that we have, on the average is $4,000 to $6,000, can be now reduced to $2,000 payment. It's a one-time payment. You can do 5 crowns, you can do 20 crowns. it's still costing you the amount the same, except for the blocks, which are about $30. The learning curve is 2 to 3 months, so that's a little bit of an integration into your practice. Complete isolation, as I said. Some people call it bulky equipment. It basically rolls from room to room, and we haven't had an issue with that. These are some publications. I'll give you a moment to type them down. Just some good overall basic knowledge of the digital scanners if you're interested. We look at the color of the adjacent teeth with the patient, old crowns, old restorations. Smile analysis for the patient. If we're doing anything in the anterior, we kind of show them the photographs, and that really helps them figure out what we're trying to achieve if we're doing single unit implants or single unit restorations. We always feel that patients' concerns are priority, and we'd like to hit these 5 topics: the time, the pain, the provisional restoration if they're doing implants, the predictability, and the fee structure. We try to get that all out of the way and make sure that their concerns are met. At the consultation, we'll do our radiographs, photographs, our interview with the patient, really sit down and really try to get to know them. It's not done in the operatory, it's done in a separate office in a private setting, and that gives you more time for the patient to really kind of discuss their issues and what's happening. And we give them the treatment plan and the financials. For an implant consultation, I just want to list some highlights that we use. Patient expectation is one of the priorities to talk about implants. They're not sure what they're getting. They've heard many different stories from the internet and their friends. So we like to clear all that up from the beginning. What is their expectation of a single unit, multiple unit, full arch? If they're going from a denture to an implant, what are they really expecting? We try to show them photographs and different models of different restorations to kind of get through that consultation. So that's a good hour for us when we do our implant consultations. In the aesthetic zone, we're looking at evaluating the smile aesthetics and the tooth aesthetics. If we're going to replace one tooth, what are the other teeth looking at? If we're going to replace 2 teeth, how is the occlusion going to affect it? If we're going to replace 4 teeth, are they going to meet together? How is the tissue going to look? Do we talk to them about the tissue profile if they've lost a lot of hard tissue and if they need grafting and so on, different kind of procedures. So there's a real discussion on aesthetic in the aesthetic zone for any kind of anterior implant restorations. And of course, we can't do anterior aesthetics unless we have posterior support. So many times we'll make sure that the support system is in the back posteriorly, and now we can go ahead to restore the anterior. Occlusion must be ideal or acceptable. One of the big things we discuss is vertical dimension of occlusion. That's going to be another webinar coming up soon. The changing of the vertical dimension, how we use CAD/CAM for that as well, to restore vertical dimension, restore back the patient's position so that anterior teeth are not cracking and breaking. We usually use diagnostic casts. We usually make them full contoured, whether it's 4 teeth or 10 teeth. We try to do that as much as possible. And then we will use the Omnibac stents for our surgical guides, provisional restorations, and for the guide for the laboratory to be able to make our abutments. So we use the wax up and stone model, and then we do Omnibacs of these. Options for digital dentistry: we can scan single teeth, multiple teeth. I'll show you how we use the different types of scanners for different situations and the in-office milling. So that's sort of like the overall view of what we're going to talk about. We started with our posterior restorations. The blocks are very different colors, so we can start picking different colors. You can see the shading is not perfect in my first couple of cases. These are my first few patients that we treated in the beginning. So we started learning about the shade matching, and yeah, basically it's just picking the right block for the right type of tooth. Now with the different translucencies and different monochromatic and multichromatic blocks, you really can get the colors to look good. We know the success of CAD/CAM has been working. The radiographs are much better than anything we've done in PFM work, so we can see that over the course of different type of publications. And now again, with the monolithic blocks being real life, they're translucent, they're fluorescent, dentin colors, different matching, and really get a great color, different elliptical positions that we can use too with different machines. So let's take a look at our first anterior restoration, one of our first that we did. When we get that complicated color, we see this patient had an accident, a car accident, and her laterals have been chipped, and her central has been chipped more to the point where we can't just do a bonded restoration. So we basically do an ideal contoured composite. What that is a buildup of composite. We have powder, so we'll spray the powder, and then what you see on the right in this view here is the actual scan of the provisional. Scan of the provisional gives you the ideal contour the way you want it. That's why the provisional is a really good way to go when we're doing interior work. Once we do that, we do our preparation. We scan our preparation, and we marginate. So you'll see the margination of that. Again, it's ditching your own dye and getting the perfect position of that. Here we use the Vital Real Life block. You see the different translucencies and the elliptical view. The elliptical view of that scan and of that restoration, we're going to bring out a little bit more translucency on the incisal and less translucency on the body. And you can see here the different types of patterns showing the fluorescence and the translucency of that with each different block. This was scanned with CEREC, and we see the anterior design that the proposal that the computer gives us. So here you see the trine of the first restoration, and now we're starting to contour it at different views. We're taking the photos at different views from behind, from the side to the right, and we're trying to make that angulation just right and contour the tooth. That's probably the biggest critical point in anterior restorations, is actually contouring it to get the light refraction. You see the shade is matching as a depth shade. We're going to do this later with all the different stains that they have. We're just trying to get the shape and the incisal translucency, the angles, to be in the right position. Once we do that, we use a little bit of stain and glaze, and you see here I've added a little bit of check lines with the white. I put a little A2 shading at the top, and it really gives us a good view of a nice natural tooth matching the other tooth there. Just wanted to go through the models of implant impressioning. We're going to talk about implants in a second. So the first way is to make a regular standard impression fixture with any implant. If you send that to the lab can pour the model, then it can digitally send that file, and they can scan it if they have a scanner to a digital file SLR. They can make the SLR model. So the digital facility will make the SLA model and the CAD/CAM abutment. After that, the laboratory can make the crown, send it to the dentist. So that's one sort of model of working with CAD/CAM designs. The other portion would be if they make the coping for the crown, sending it to the DDS tries it in, takes a pickup impression with regular impression material, then the lab makes the crown delivered. So you see, if you're making multiple units, sometimes we'll send out for the coping. If we're making 1 or 2 units, we can go right to finish. So that's model A of digital CAD/CAM abutments and CAD/CAM crowns. That's when the dentist does not have any kind of scanning capability. And so something like this, where you have an ideal contoured crown that really, really supports the tissue. We're going to talk about how that tissue is supported, as opposed to a prefab abutment that may be very small and not supporting the tissue. The biggest complaint that we have is that food gets caught between these areas. So by extending the design of that abutment and making it look like a molar, it actually decreases that food impaction, and now the position of the implant that has been replaced is a much more lifelike size of the tooth. So here, a good way to do that is if once you get the abutment back, if you have a scanner, you could just scan it. So once you scan it, it's basically like a regular preparation. You can't tell that that's a tooth or that's an implant because of the size of it. It doesn't look really small. Sometimes you see some restorations and the prefabs are too small, and that's going to allow for a lot of food impaction. So we could scan it, we can marginate, we can mill out a crown in this situation. Now, looking at Akbar's publications, one of the things I want to stress is not the 1 point or the 1.2 millimeter collar like prefab abutments, but more of a big shoulder here that's going to support the porcelain coming down. The pressure of the bite coming down is going to be much better supported with a 1.5 millimeter or even a 2 millimeter step, gingival step, for any kind of ceramic restorations, especially if they're CAD/CAM. So what you see here is that support system holding an Emax restoration, and you see that margin there is a lot fatter and bigger than a prefab abutment. Here we're going to minimize the tissue. You can't see the tissue, but it's actually right here. It ends right at the line level, and it ends right here. And that triangle is really small, like a natural tooth. All this is filled in with soft tissue, which is all right there. That's a big thing in terms of the designing of the abutments. Model B would be an encode technique, which basically is we're going to make an impression of the encode. We're going to take a final impression of that if we don't have a scanner. Send it to the lab. The lab's going to scan it for us. And then the 3i facility is going to pour the model, make the SLA models, send it back to the lab. Lab can scan the crown, mills it, and gives it to the dentist. So even if you're taking a final impression of an encode, this is a great model to use because it uses the encode abutment and it uses a lab scan. And then if you don't have the scanner yet, it still allows you to get a great result. And that's a 2 to 3 visit protocol. If the lab makes multiple units, it can make copings. You still have to take a pickup impression and go to it. So here's an example of that where you have a posterior restoration. We don't have to take a fixture level impression anymore. We're going to take an impression of the codes, and here are the codes. I'm going to point them out in the next case, but here they are right here. Take a regular final impression there. The analogs are placed by the robotic arm, and the CAD-CAM abutment is designed. But now, because we have our CAD-CAM impressioning, we can actually take a CAD-CAM image of the end code, so a scanning image of the end code, and basically that gets translated to a different software at the 3i facility, and they can design, sorry about that, let me go back, they can design their abutments based on the CAD-CAM file that they delivered. So now the emergence profile is created, and we'll talk about emergence profile. The question is, how do we want our angle here? Who makes the decision as to what type of angle we want our abutments? Usually it's the designers. So now we're asking the designers to email us this file, and we can physically measure it on a digital scale and find out that our degrees in this situation is 10 to 15 degrees. Every situation, every restoration is different. So some restorations we can push out to 15 degrees, but as you can imagine, as this angle changes and gets wider and increases, this tissue level will be pushed out. That will cause that tissue to be a little bit lower or maybe get recessed over the course of time. So this angle is a critical piece, and we're going to get into that in a second, maybe a minute. You see here the digital design here, the margins are a little bit wider, okay, and they're going to support that restoration. It's an all ceramic restoration. Now look at this design. You may say that's too obtuse. That angle may be 55 or 60 degrees coming outward. So is that the right emergence for this case? So each case is a little bit different. By looking at the designs, we can now look at it and say, well, is this tissue going to be pushed out as that angle comes on an obtuse level? So we figured out there's a formula for that. I'm going to show you that in a little bit. But making sure that we're looking at our designs as clinicians is going to help out the final result. You see here we have a 1.2 to 1.5 shoulder. We want to increase that area there to get more support for the ceramics. And as we said here, the angle here is 20 to 45 degrees, but who's making that decision? It's a critical thing. In terms of occlusal clearance for prosthetic material, we want to keep that at 2 millimeters. I want to have a lot of support for my ceramic material. We can have a PFM too. You'll need less support and less clearance, but if you're doing all ceramics or Emaxes, we want to have that good 2 millimeter support system. So again, you see this, how it's supported in that restoration. Let's look at the end coat abutments. They're available in titanium nitride coating, which has a gold hue, and zirconia. So here's the actual coated abutments. Those of you who used it know the advantages. Those of you who haven't, let's just touch upon it. The width, it measures the tissue depth, it measures the angulation of placement, it measures the margin placement. So that's what all these codes do. All these codes give the information to the computer that dictates all these positions. Now, for the technician to have all these pieces of information, we also want to do a couple of other things. We're asking the technician, we're asking the dentist to send a photo. Send a photo. You see here, there's 3 or 4 millimeters of depth of tissue, and there's no depth of tissue. Well, these margins, when they come out of that abutment, they can't be the same. They have to be different. So we like to send a photo of the biotype of this patient, because that may help the technician design a different type of abutment for each scenario. We see here that the most important thing is to show them where the bone level is. We can see here that this bone level cannot be extended. That margin that you see here, this margin here, cannot go further out because there's bone there. If the technician does not have that x-ray, they're not going to really know how far they can extend that abutment. So by having the biotype and the bone levels, they can predict better that emergence profile from each digital abutment. And that's going to save the doctor and the patient a lot of time, because they have to sit there and play with it and change it because it's hitting the bone. So that's a critical factor of the tissue and the bone. Here's an example of 2 abutments that were designed. We're trying to get a wide emergence profile. We're going to make 2 CEREC crowns on these. You're going to see how they basically support the tissue, close the gap, not too much, but just enough to get a nice triangle of exposure of like a natural tooth. So it's not too far open, you're going to have food impaction. Now here you have a second molar, so you can have a little bit more material there. But still, a lot better than a prefab that's basically a circle. And then the crown has to do all this work. So we're trying to get the abutments to do a lot of the support system and minimize the food impaction. So you can see the two restorations here. Now let's talk about occlusion a little bit. When we talk about occlusion of implants, a lot of folks talk about light occlusion. So how do we make our occlusion? This is a natural tooth here. We use artist foil, red paper, and blue thin paper, which is actually the thickest. It's 80 microns. So when we do our first test, we want to have our natural teeth hit in our centric position. In centric position, these teeth may have a little intrusion. So the word has been sort of floating around that we want a little bit of light occlusion. Well, we have to measure light. What is actually light? If we say that light is 20 microns, then our red paper should slip through. If our red paper slips through, then we know we're at 20 microns. If we double over our red paper, now we're at 40. Now you could say light is 40 microns. So depending on what you consider to be light occlusion, that will vary for different patients. We also know that the depression of a second molar is a lot greater than the depression of a first premolar. So that may take into effect. I think what we all want at the end is have a centric position here, light occlusion for me at 20 microns slipping through, so that if there's depressibility, the implants come into contact there. When we go to the blue paper, we see the blue paper is going to hit everywhere because it's a lot thicker. So if you're just using blue paper, my recommendation is let's pick up some red paper and see where our contacts are, because this is a lot more precise because it's a closer occlusion. We still want our red paper coming through, but our blue paper is going to hit everywhere because we're at 80 microns. So just a little tip on using the articulating paper to measure our light occlusion. Let's go through this patient treatment and see how we accomplish this. In this patient, this tooth is a hopeless tooth. It's got a lot of infections. It's kind of hurting the patient. But if we take it out, we lose our whole provisional chance of making it provisional. The patient's going to need bone grafting here, and we see that after what we evaluate here, they're going to need a bone grafting, then placement of implants. There's only 2 millimeters of bone there. So the scenario, let's go back. The scenario here is placing implants, placing a bone graft, waiting 6 months, then placing implants and waiting another 6 months. That's going to increase the treatment time to 12 to 14 months. Well, if we extract this tooth right away, then we're going to have a really tough time giving the patient a provisional. And for me, a removable provisioner on top of a grafted area may cause problems over the long term. Excuse me. So what we do is we use pain management, antibiotic therapy, and pain management to help the patient get through that tooth and help it survive for 12 months. We need to keep that tooth stable for 12 months. So we'll prepare the tooth, give a provisional here, from here to here, from number 2 to number 5, and then while this is healing, we have a nice fixed provisional, and we're holding on to this tooth as much as possible. On the other side, same problem. We need grafting and a long treatment time. So this patient's going to have a sequential 12 to 14 month treatment time, and then we have to evaluate the most posterior tooth there. So what happens after treatment, 12 to 14 months later, our implants are placed. We have a 13 by 4 and a 13 by 5 here. Encodes abutments are placed. Dr. Diamond did this surgery for us here in the city. And here he places the encode abutments, and what we see again is the coated or healing abutments. So let's take this at a restorative standpoint here. What's your regular protocol? Your regular protocol would probably be to remove the healing abutments, take fixture level impressions, get abutments back, try them in, and then hopefully everything fits and the margins don't move around. Well, think about taking a final impression of this with material or with a scanner. If you have a scanner, it would be a great way to just take a final impression of 4 implants. So the first restorative treatment, we'll take our impression, we'll look at our CAD CAM abutments, and we'll try to maximize our emergence here, maximize our emergence, so we're actually reviewing our final abutment instead of just kind of waiting and hoping you get something that works. We're trying to close the space as much as possible here. We're giving the technician a biotype photo and a radiograph photo. The patient treatment, the laboratory sends us back a final model that we can scan now. If we have a digital scanner now, we can take this and scan the final abutments. As you see here, we've opened up the actual model and created this emergence. You see that the line around it is what we've created on the model, and now here's the final abutment margin. We're going to marginate that, and then we're going to create our restoration. This is our first restoration that's created, and then this is our second one. So as you see here, we've created this emergence so we can actually make our provisional fit around that implant and really support that tissue to minimize food impaction. We can envision that the final restorations will look something like this. We're going to use an Emax block in this situation. We want a nice strong material. And again, here we're just helping the restoration by designing this emergence as further out as possible. But if we have a good margin here, it's going to support that ceramics. And that's really the key to getting these designs. Now, when we look at our occlusal analysis of our restorations, what better way to control our occlusion, making it lighter, making it lingualized, making it in 4-point contact, than with a digital computer? So the precision of these systems are so good that you can get this to 80 microns, to 40 microns, to 10 microns, and when you mill it, that crown is going to come out to that specificity. Now, each system has a different tolerance. So my machine may be red may equal to 85, and somebody else's machine may be red will equal to 65 microns. So that's just a calibration issue that once you know your system, you'll be able to get your occlusion dead on to position that when you're trying on your crowns, you're really in a much better state than we were by using models and casts. So we try on our abutments. They fit into a great position. The tissue is going to be maintained here and supported. Okay, so we have computerized abutments and computerized restorations. We're going to use an Emax monolithic, very strong material. The research is done by the people at NYU, Guess and Zavanelli, Thompson. All did some great analysis of the porcelain compared to the porcelain, the lithium disilicate compared to the porcelain zirconia. And of course, we know that the weak link is right here. The weak link is from the aluminous oxide to the porcelain. That's where the cracks happen. On a monolithic block, nothing's going to break. Even though this megapascals is less than the zirconia, we know that this is not going to break from all the studies that were done. So what we do before the patient arrives, we actually mill our pre-glazed state. We will try the abutments in, then we will try the crowns in, check our contacts, check our occlusion on all 4 restorations. So this is the pre-glazed phase. Once we like everything that we have, and we're happy with the contacts. Now, one of these had a contact that was open, and we had to add it. But again, we have everything here in the office, and we could do our staining and glazing. Once we like the restorations, the occlusions in the perfect position, then we do the glaze phase. So we get our final restorations. They're cemented in position. But the big question is, again, occlusion for second molars does become a factor. Where is the occlusion on these teeth? Should it be light occlusion? Should it be at 80 microns, 20 microns, artist foil? That's a big discussion, and nobody's really published on this, so everybody's got their own sort of philosophy. I feel that it's a posterior tooth. The 2 posterior teeth have to have a stability for the joint, and I think that they have to be in contact at the same time as the natural teeth. Okay, so we feel that they should be at least 1 or 2 point contacts here, stabilizing the jaw in centric position. The other question is, what kind of cement should we use? Emax was a material that has been really made for dentin bonding, and a strong material for dentin bonding. Emax was not created to be cemented onto titanium, because the question is there a real bond to titanium? And some people are doing the research on this. So the question is, do we put it in with provisional cement, or do we put it in with final cement? Remember, each time you make that decision, you have to kind of pay the consequences. Provisional cement, the question is, can I get it off? We've been using Tempon and Temrex, and we've been able to get it off with our GC pliers. If we're using a permanent cement, it's going to be Reliex or any kind of dual cure cement, but then we can never remove those crowns if any kind of screw gets loose. So my advice is, check the system that you have. Or do you have some screws or the possibility of a screw loosening? You may want to go with provisional cement. Or do you have a good internal connection that you really are sure that that screw is not going to get loose, and you can go with more of a permanent cement. So as you can see, the Model C here, we have 100% digital impression technique, and that's if the dentist has a scanner, he can scan the encode with either Lava 3M-COS or with iTero or with CEREC today. In about 2-3 months, we'll be able to scan it with E4D as well. All the beta testing is happening now. But when they scan it, they can email the file to 3i. Then 3i is going to take the model. It's going to separate the two files, make one SLA model, and then make the second one make the actual abutment. It's going to send both of those things to the laboratory or to the dentist if the dentist has a facility. And then the laboratory or the dentist can scan those abutments and make a crown. So that's 100% digital. It takes 2 visits for us to do that, and we're really controlling the cost and the time of fabrication. Let's continue on. So let's talk about emergence profiles. In a digital software, we can't control the digital profile of any digital abutment. So we can see here where the angle may be maybe 20 degrees, and over here on this one, it's about 45 degrees. So again, the decision has to come a little bit with the technician and a lot with the dentist. Without looking at that, we're just taking a chance. We're looking at a model today where X is the depth of the tissue. When you remove the healing abutment, you can measure the depth of the tissue. And you can envision that as that emergence increases at each angle, that tissue will actually be moved down. So the angle, the tissue is directly related to how that angle gets displayed. Using this sort of mathematical model, we've created an algorithm that helps the technician and helps us out to figure out where the margin should be. So let's take a look. Multiple unit full arch restoration. This patient treatment had a lot of periodontal disease, had some old restorations that were failing, and teeth that had periodontal disease that had to be extracted. So we see here that this tooth was hopeless, this tooth was hopeless. Perio treatment started. We made a full arch provisional for her to stabilize everything, and then we did sequential extractions. Here's the bone grafting from the surgeon. This implant was placed and immediately restored just to hold the provisional, so she had something to wear. This is the 3-month post-op. And then over the course of time, everything healed. We did a second provisional, and we stabilized everything. We used Luxatemp in this scenario. This was a root-amped molar that we kept. It was pretty strong. And then the 2 implants were being placed here, and the 2 implants were being placed here. So we provisionalized her in 6 months, stabilized her occlusion, gave her better vertical dimension, increased her canines to give her some guidance, and she had posterior disclusion, which actually strengthened all the teeth just by changing her occlusion. Once the implants were ready, our encodes were fabricated. They're in perfect position now. As you can see back here, the last implant actually failed after a year. We were loading it immediately, and that's in treatment right now to be replaced. But right now, we have to make a final impression. So you see here 2-unit splinted zirconia bridge, 3-unit zirconia bridge, individual units, and then again another 2 units splinted, and then a PFM ceramic metal crown because this was a root amp and we couldn't get a shoulder on it. We only had a long bevel. So that was our proposal. Now what you see here is the powder sprayed for the Lava COS. Here's the digital impression of that. That digital impression took us 22 minutes to make. Now you may say that's a lot of time, but a lot of things are saved in this visit. The occlusal factor is very big in terms of getting the right occlusion. The model work, there's none to be done because you're going to be sending that whole model out. And it's a digital file. It's a lot quicker in terms of if you add up all the costs of the impression making, the pouring, the inaccuracies, it's still going to save us a lot of time. And that, again, took us only 22 minutes to make the final impression. Once we got the copings back, we tried them in the mouth. And then once we have multiple units, we're going to still take a pickup impression. So what you see here is the model after the pickup impression was made. Okay, we'll take another vertical dimension with wax. And now we can go right to finish. So our restoration in terms of our visits was 1 for the digital scan, 2 for the trying of the copings and the metal coping, final pickup impression with occlusion and face bow, and the 3rd visit we're going to go right to finish. So it's really saving us a lot of time because the accuracy is right dead on. York Dental Lab did this. Their numbers right here. They do a lot of all the digital scans that we send out are to York Dental Lab and also Rowe Dental Lab, which is in Ohio. So those are our two primary digital laboratories. And they have all the different types of scanners and digital software. This is the day of insert. You see a little bit of blood there. I apologize for that. But that's the day of insert, so we're cleaning up all the cement. You see the aesthetics are good. They're maintained. We have a good occlusion in here and 2 units here. 2 units are splinted. This is a single restoration, single, and then a 3-unit restoration. And we're waiting for that last implant to heal. It's going to be ready in about 6 months. And that's how we do our full arch restorations. When we get into individual units, we're now using our E4D, and our margination can get up to 17 times of power. So we really can look at our margin very clearly. The E4D technologies allows us to get really close. It also allows us to get some feedback if we want to close the margin or close the spacer. It gives us a lot of variability with that. Our contact designs, our thickness, it can show us the thickness based on a calibration color effect. And of course, it could slice it. One of the biggest things in terms of advantages of designing our crowns now is we can get this sagittal slice and see how much material we have on the facial or on the lingual and really make a uniform crown. As you can see here, we can slice it from the sagittal, from the facial, from the interproximal, and really get a sense of what our restoration looks like. So something like this, when you look at the occlusion here, you can pick up these inadequacies of material where you would never be able to do that with waxing and casting technique. So you see here, we have plenty of room here, but here on the occlusion, it's very tight. So it allows us to really make those changes when we're doing our final restoration. We can also make copings. Our protocol now for 4 or 6 anteriors is making Emax copings and then picking them up and going right to finish. So it's really a great technique to be able to make these restorations. And again, the designs for us is a lot faster and cleaner. When we combine those two technologies, we get into the implants and the anterior restorations and the posterior restorations that we're combining the two types of digital softwares. And this is where it gets exciting, where we've been doing a lot of patient treatments this way and trying to publish this as fast as possible, because I think I need to get the dentist to realize the potential of these systems. So the coated healing abutments have been published from various authors. We see the different images from all the different companies of the encode, the Bellatech encode. So it's the scanners are really incredible in terms of their accuracy. So this was done by Dr. Nick Toscano here in New York City. The implants were placed. The first restorative appointment is on your right. So we will scan that with a lava full arch scan. This one takes about 7 minutes. Really picks up some great detail here. Our angulations here, when we get back our design, again, we're going to sort of really tweak this and make sure, giving the technician the biotype, the gingival health, the radiograph, and our formula, which I'm going to talk about in a second, really can get us to the point where the digital CAD/CAM abutments can really just fall into place. That's what we want. We don't want to be able to, we don't want to be adjusting and changing and moving tissues around. We really want to know where they're going to fall into place, because that'll help the tissue maintain itself. So we give the technician the photo of the biotype, the gingival levels. So now you can see here the angulation can be displayed up to 15, 20 degrees without touching the bone here. That's a critical point when designing these abutments. So here's our formula. Our formula is called Finding Z. We're in the process of publishing. We submitted for publication at this point, and we're just reviewing with the authors right now. And what it basically is showing us that the X value is that value in the depth of that tissue. Now, X2 will be this line that's created when we actually make the abutment. So the angle of that abutment is X2, which is the same value as X1. The angle created in that abutment is critical to the evaluation of that emergence profile. Once that angle is created, it creates a position of Y. Y goes out to a certain point, and that is measured. And that gives us the change in Z. Change in Z is directly related to the angulation of that abutment, and that's a mathematical equation. So we've developed an algorithm that will be able to send to our designers and email to our doctors, and they will be able to predict closely, not perfectly, but pretty closely, where those abutments are going to end up. And you can see the different designs here based on all the formula and the radiographs. Now what happens is the digital model is created, the SLA model is created at the facility. It's then sent to the laboratory with the final abutments. So we've taken the image, we've sent it to 3i. 3i has created the SLA models and sent it to the laboratory with the 3 abutments. The 3 abutments are designed, and now this model is used to make the final fabrication. These are Emax full monochromatic, monolithic Emax crowns. You can see the marginal integrity is excellent on the model and on the abutments. And now those are tried in the mouth at the second appointment. So the second appointment, the abutments are tried in, the radiograph is taken, and then we'll try in the first restoration, the second restoration, the third restoration, and make sure the contacts are good and make sure the occlusion is good. And again, a big wow factor when you try these restorations in, because they're really fitting in an ideal position. We have an internal system, so we're going to cement these provisionally because we just in case we want to make any changes or if there's any movement, we want to be able to take them out. So we're going to cement those with a Temprex or a Tempon, depending on the height of the abutments. This is the post-op of 18 months. You see the tissue maturation is good because it's maintaining because we use the right emergence profile. And then we can also check our occlusion. We're going to take off this contact. It's a prematurity. You want to get rid of that. But that's really the only contact that we changed. Everything else fell right into place. That's the only contact that was a little bit high in this situation. And again, it was literally less than a minute to adjust that. Let's go to the anterior restoration where we're going to plan our abutments. And this is what we're doing today. The patient presented with a removable restoration. We have to do some soft tissue grafting, so we're going to fabricate an Emax bonded bridge. That's our protocol today, a bonded bridge for anteriors. And while that graft is being done, and Steve Chu has been talking about this, whether each restoration is each tissue is a grafted or non-grafted or immediately placed. Pretty much all our implants are placed with the grafting, and we're not loading them. We're using that bonded provisional to maintain that tissue. And what we see here, Dr. Najat had done this surgery. The encode is placed at stage 2, and that's maturing the tissue. We see the bonded restoration is still there. Then we're going to scan that with our lava. The lava is going to create an SLA model. Here's the lava scan, perfect occlusal registration. That gets sent to 3i facility. They'll make their final design, and if you see here, the margin is sort of about a millimeter below the tissue. So how is that determined? Look at the angle that is created here. Look at this angle. And you can imagine that this angle could be short or it could be wide. That's going to change the tissue level. So when I get these back from the PSR facility, I consistently check these. So this is their design, and this is my design. So we actually made, just to prove the point, that we made 2 separate abutments and tried them in. One was my design and one was their design. And you can see here that their design is a little bit too far out. And I'm going to show you a video right now that shows you the difference between how to create this a profile or this profile. So when we're doing our designs of our abutments, you can see here on the video that we're going to use the 3Shape software and change the mesial and distal contour, as you see here on the video. As it changes, you can imagine that the tissue will respond differently. So a deeper shoulder or a longer shoulder will change the design process of the final abutment. We can also extend out. You see here the angle is being extended on the facial. That's going to cause that tissue to kind of move down, and that's where we use the Z value. The squares represent 1 millimeter, so now we can measure that. If we turn it to the facial view, we look at the position of that margin, and we have to maybe kind of bring it out a little bit to close the contact next to the lateral. We don't want to keep that lateral position too far open. Then we can reduce the axial wall, which will give us a wider platform, increase the mesial floor, and then decrease the axial wall there. That's going to give us a lot of support. Now, if we look at the facial margin, it can go up or down, and those are the millimeters. You see it's 2 millimeters deep there, and now it's 1 millimeter deep, and now it's 0.7 deep. And again, that's going to change the profile of the tissue. Now, if we look at the facial contour, this is critical. A lot of prefab abutments are concave, or they're straight, or they're convex. And you can see the differences how we can create that. So depending on our biotype and our tissue and our depth, we can change that angle position. So using the formula, the biotype, and the bone, we can sort of really idealize those positions. Okay, in this patient treatment, a patient had a non-vital tooth that needed to be extracted from recurrent decay and recurrent infection. You can see the fracture is right there. The grafting was done. The tissue grafting was done. A bonded provisional was made again. We like to make the bonded provisionals because they really preserve the tissue and their fixed position. You can see the graft is healing originally, and then slowly it starts healing here. In about 6 months, we put the final implant in, and we provisionalized with the performance post. We use some Teflon here to keep our margins and our contacts good. We use a little bit of flowable composite and made our nice provisional to maintain the tissue. And then about 3 months later, we removed that. We have a nice, good healed, grafted area, a good support system. But as you see here, the biotype is very thin, and we don't want to push that too far out because then we'll start getting some recession. So again, going back to the design part of this, we want to minimize this angle. This angle here, if it kind of gets too extended out, it's going to push that tissue up. So we want to minimize the angle here. We have the photo and the radiograph to the technician with the formula, and he can create a nice, beautiful abutment, and then I can go back and check it. One of the changes that I made in this restoration was I widened the platform here. We don't need a short platform. We like a wide platform to get good support for that ceramic. So a total of 6-week maturation after stage 2. You see the tissue is maintained at the same level of the natural dentition. And the radiograph here shows you that you're not going to be pushing out that emergence too far out into the bone level, which should maintain that tissue, and it did. Once we have the tissue maintained, we take a CEREC scan and do our regular protocol, scanning the provisional, creating an ideal contour, and then slowly contouring it, being careful not to hurt the tissue. And then we wind up with our staining of an A1 stain and our glaze, and getting this final result with that tissue position really maintained there from that emergence profile that was created by the final abutment. So CAD/CAM restorations can be successful. For us, it's been a daily work in progress. We're using some great blocks, some fluorescence and translucence to get the anterior shades to look good. Computerized dentistry for teeth and implants may be more predictable, cost-effective, and timely than conventional techniques. So I'm hoping this kind of stirs up some controversy and some discussion about what the best way is to restore our anterior teeth, our posterior teeth, and our implants. The digital dentistry, the future is here. We're doing a lot of central incisors, and we can actually match shade a lot better than our technicians because the patient's right there in front of us. The ideal dental practice, well, my vision is to have associates taking the scans and then other people doing their try-ins, and I can be somewhere and just kind of doing my digital designs from afar. From the New York Smile Institute, I hope you enjoyed yourself. I hope you learned something. If you have any questions, please email me at drdean@nysi.com. And thank you for your time.